of hand, how many of you have got at least one patient of Exon 20 insertion in last 1 year? Okay, so if you look around, there are pretty good number of people who have got Exon 20 insertions. Samir, let me start from you. A few years back, we were happy to get the reports of EGFR mutation itself. Now, those were basic point mutations and deletions. Now we get Exon 20 insertions. Why is this shift happening?
Getting a lot of NGS right now.
So the question is now more and more comprehensive genomic profiling has been done, and then you have started having more and more Exon 20 insertions. We see. Akhil, you are actually part of the Tata Molecular Tumor Board. Can you enlighten us, when you see Exon 20, do you take at a face value that all Exon 20s are the same, or some are more bad, some respond to other kind of treatment like first-time treatment? It is always that if you have Exon 20, it's always bad.
Exon 20 insertions are actually a broad term. It is actually at least 40 different mutations are there. Just answering the previous question as well, RT-PCR Cobas version 2 which we use has total of 44 mutations including all the exons. While there are only, for Exon 20, there are at least 40 different types of mutations too. So RT-PCR, that is why I'm not able to identify most of these. Now, when we discuss the cases in a molecular tumor board, we tend to see which exactly area where this Exon 20 insertion is. For example, YLVWM mutation, which we know, late mutations, they are somewhat sensitive to first-line TKIs or afatinib, some are sensitive to positinib, but now positinib is completely out. So I think they have definitely, this advantage is that they will cover multiple.
So the point which Akhil is trying to make is that when you do a CGP, there are 40 plus odd types of Exon 20 insertions which are there. And when you do a CGP, you are going to catch them. This can be in the C loop or it can be the helix loop. But whichever loop they are different types. And whenever you do an Exon 20 insertion, the reflex action should not be to think for amivantamab. The reflex action should also be to have a look at which type it is. There are few types of Exon 20 which can respond even to your first line TKI. Now, another thing is, if you get Exon 20, and of course this is for you, if you get Exon 20 insertion and you get, let's say, Exon 19 mutation, so how would you approach it?
So there are chances that we might have concurrent mutation in EGFR. We see there 5 to 10% patients have concurrent mutation. Then two things come into matter. First of all, the graph of that mutation, whatever mutation is there, it comes into importance. If both of them are high, low, it depends. One is a pretty high, second is not that much high, so it goes in favor of that particular mutation. But if yes, if we have same kind of mutation with a high frequency, so the dictum is to go for the most the commonest and the best therapy for particular, we are the best therapy for a drug. But these patients tends to do not that much good as compared to just having a single mutation.
So what is trying to tell is, if you have an Exon 20 and you have sensitizing mutation, you would probably want to focus on the Exon 20 because that would be giving you a worse prognosis. Shruti, so as an approach, most of us would send an NGS. Would you send out only a tissue biopsy, or what's your approach? You would send a tissue and a liquid together, or a liquid followed by a tissue, or what would be your way of doing it?
So upfront I will send tissue only, and if supposing there's a situation where there's no tissue, then maybe I will opt for a liquid biopsy. But I would actually insist on doing a repeat biopsy if I can see a lesion, because many times I have seen cases being missed on poor cellularity blocks of pleural fluid, also on blood when there is no cell-free DNA. So better to go for a repeat tissue biopsy with a good interventional radiologist. It's more so possible. So unless and until there's only brain lesion or only bone lesion, it's usually possible. So that's what.
Okay. So let me give an example. That if you have liquid, you believe that if the tumor volume is high, the liquid would should be. If there are multiple lesions across, there are multiple bone lesions across, then you might get a liquid which is high. So why don't you? There is good amount of data which says that if you do tissue and liquid simultaneously, you might be able to catch extra 15 to 20% of mutations. So why not go for a concomitant testing of both tissue and liquid together? What is the economics which is stopping you, or you want to do it? What is the reason why you're not opted for both simultaneously?
So rather than for the upfront setting, maybe during progression, I would want to do a dual sort of testing. But at upfront, if tissue is still missing some lesions, this is new, that maybe I will also build up this, that if this is substantially adding, that maybe we can offer that to patient, but it may become an issue cost, because getting one test only may be not very feasible for all patients. So we do a consolidated small panel NGS or something. But for patients where there's no issue, I would want to do it for few patients and see what difference it is making.
Samir?
It's always ideal actually to do both, because if you do a tissue immunity also. Only problem with epilepsy is that most of the labs are not doing, means I am not very sure the quality of epilepsy I guess in India.
Okay. So
that is the issue.
Correct. The depth which you require, the coverage which you require, we are not very confident that most of the Indian labs are there with the liquid. So in your clinical practice, out of 100 patients of lung cancer, how many would have Exon 20 insertions? 1 or 2. Does that change for anyone? Okay. So let's come to the key question. If you have Exon 20 insertions, what is your treatment of choice today? Ankur, we can start from you. So let's say upfront patient, Exon 20 insertion has come, and it is not one of those type which is sensitive to the first generation TKI. What's your choice and why?
As of now, we have a data with amivantamab upfront, so my now preference would be to use amivantamab in the upfront setting rather than in the second line setting.
So the preference would be to use amivantamab alone, or it would be amivantamab, pembrolizumab, and carboplatin, all three together?
Amivantamab plus chemotherapy.
Yeah. So the recent study for Exon 20 in the first line setting clearly demonstrated that addition of amivantamab to pembrolizumab and carboplatin in Exon 20 insertions leads to a benefit. What are the challenges, Samir, in giving amivantamab? What is there might be people who may have not given amivantamab. So what would you advise in the first dose of amivantamab? What needs to be done?
So infusion reactions are the major issue in the first dose. So we have to divide the dose in 2 days. So just give 1 vial on day 1 and then remaining 2 vials on day 2. The patient already well, then you can next dose, next cycle, you can give all the 3 vials required dose in the 1 day. But you have to give adequate pre-medications, because sometimes infusion reaction can be severe also.
Yeah. So when the initial studies were done, when amivantamab was tried to be given whole dose on the first day, they were actually 90% patient had infusion reactions. The dose is dependent upon weight. What Samir is extending of 3 vials, and 1 vial is of 350 mg. It is a 1050 mg dose. That's for the patient whose weight is less than 80 kgs. If the weight is more than 80 kg, the dose is around 1400 mg. So, as you rightly pointed out, when in the study, when they divided the dose on the cycle 1, on day 1 and day 2, that is 350 given on day 1 and 700 given on day 2, they saw that a significant amount of reduction was seen. And the infusion, as expected, rituximab infusion period is also different in the first cycle. If the patient tolerates the first cycle well, then you can go with the 75 ml per hour infusion speeds. And it needs to, as you correctly pointed out, it needs to be given quite a bit of anti-allergic medications.
There is no need of nothing codon set.
Yeah, correct. Yeah. Shruti, if you are going to start a patient on amivantamab, apart from CBC, biochemistry, what we all do, any other test you want to do for this patient?
So as such, electrolytes I would want to do, and at the baseline I would want to do thyroid profile also.
Okay. So in addition to that, the drug manual, the FDA label, this drug is known to cause ophthalmic keratitis. So it's better that before starting amivantamab, you get an ophthalmology clearance for this patient, at least a slit lamp examination. This drug can also cause interstitial pneumonitis in 2% of the patient, and which can come very rapidly. So, what it would be better that if you, when you look at the scans of this patient, to see for if there are already some features of interstitial pneumonitis in a patient who is going to receive amivantamab. Akhil, patient, the initial dose is weekly. That is, you give in the first one week, and then it is. What are the things which you watch for in the initial few weeks of when you do amivantamab?
Actually, the first 4 weeks, as already discussed, in the first infusion excess are much more common only on the week 1. Week 2, week 3, the chances decline rapidly, so it is not a much problem. When the skin rash, all these tend to appear somewhat later, around 3 to 4 weeks at least, but the first 2 weeks are usually devoid of skin rashes. But when the skin rashes come, they come usually along with nail changes, and that become somewhat troublesome for the patient. Here we need to take care of extensive care of the nail hygiene. That is very, very important for our patients.
The typical rashes here, they come near the nails and they're like cuts on the nails, and very often you are going to get cuts from the patients. And this becomes quite painful for the patient. So we need to take care that they have a good nail hygiene. They do not put their hand in water or detergent water for a long time. This instructions need to be given to the patients who are evaluated. So we'll start this one from Akhil to you. So what would you say are the indications for amivantamab in today? So which are the Exon 20 Ankul is already clear. So today for Exon 20, it's first line amivantamab pemvidutide. Which are the other indications for amivantamab today?
We are replacing it already in post-osimertinib population. That is, it has already there from the Mendoza 2. There we see that it is in combination with chemotherapy and plus minus lazertinib as per the 2 arms. Lazertinib is not available with us, but we have utilized amivantamab plus chemotherapy. Off level, we have even utilized with amivantamab plus osimertinib as well.
Yeah.
But I think lazertinib doesn't add anything extra to the combination of amivantamab plus.
So what Akhil pointed out is correct. In the study which was to be done post-osimertinib post-failure, did amivantamab post-osimertinib, irrespective of MET amplification was there or not there, did benefited. Patients who had MET amplification, they benefited more. Okay, so that remains one of the choices in patients who are post-osimertinib. Would you want to use that Samir as, let's say, if you have access to lazertinib, would you today want to use EGFR sensitizing mutation, amivantamab plus lazertinib as the first line of therapy?
No, I would like to reserve it as because we have good data on Flora also, which gives us similar efficacy.
Any reason for that? Any reason for that? Why you would choose Flora 2 and not amivantamab plus lazertinib?
We have a second option of second line.
Okay, so you want a convenience option that after osimertinib chemo, if it fails, I have something to back it up with.
Also, the quality of life, the toxicity pattern is
correct.
Amivantamab is a good drug, but it has some significant toxicities which need to be managed. So we need to balance.
Correct. I would agree with that. Amivantamab and lazertinib. Nandini was one of the PI of the study. So Nandini, can you tell us about the kind of side effects which were seen in the amivantamab lazertinib combination?
So what we saw in our study patients, I remember particularly one patient had very bad skin toxicity to the extent of grade 3 paronychia. She was a young lady, 35-year-old, and to the extent that we had to stop the amivantamab because of paronychia, with the nail almost coming to toenails, and she had pustular regions on the scalp, body. So we put her off amivantamab, then restarted again, put her off, and ultimately she progressed because of treatment interruptions. It was very difficult, and it took almost 4 months or something for those skin changes and nail changes to result. She was like could not do even any instrument.
The problem is that the toxicity is very overlapping and it becomes very difficult which drug to stop.
In fact, with lazertinib, we had one of the patient who had a neuropathy also.
Patients actually.
Yeah.
One had grade 3 sensitivity, one had a grade 1 to 2 sensitivity.
So the thing is with osimertinib is much better tolerated, and we are used to having a TKI plus chemotherapy combination. Somewhere I think amivantamab and lazertinib, we would have a learning curve with this, how to manage this paronychia, skin reactions, and even with the MET-related hypoalbuminemia and peripheral edema, which Shruti, you wanted to say something? Sure.
So we'll be using FLORA2 first line. So we'll be giving maintenance commitment. Also data for leukocytes and carbo plus innovator. So what you will chemo background is chemo background what you will be choosing. Like whether you will add carbo, continue pemetrexed and add innovator, or whether you will use a taxane partner here. That would be a discussion.
So let's take this question to Dr. Kumar sir. So the question is, let's say that you follow FLORA2. You are going to give osimertinib plus chemotherapy, and the chemotherapy backbone selected by Samir is pemetrexed carboplatin and is going to give pemetrexed along with osimertinib. The patient has now progressed. He wants to use amivantinib. So his question is, he needs to use amivantinib alone, or he would do amivantinib with, let's say, paclitaxel or some.
Chemo backbone would be M-carbo means continue pemetrexed at carboplatin 2 cycles in amivantinib, or whether to use taxane here and stop pemetrexed.
If the patient has failed on that treatment, what you're giving, usually you change. There are certain situations where you continue, usually not in chemotherapy. Other places you do, and there are some fair basis for it. But chemotherapy, by and large, we have seen the same chemotherapy continuing doesn't help. So it will be. I won't get into which one. Akhil may have some different, better ideas. So, but yeah, it will be changed. That is by and large.
So I think there is no data for taxane and amivantinib.
Yeah, up till now I'm not aware of any data.
Second line, you would want to give single agent amivantinib.
You can give single agent.
Is also an option.
Yeah.
Apart from that,
single agent amivantinib is also.
Also, sir, if we see FLORA2, we have a long DFI. DFS is close to at least
25 months. Yeah.
So if patient has received carboplatin 4 cycles in initial phase and patient has never progressed on carboplatin at least, so there is a chance that I might utilize carboplatin plus amivantinib plus lazertinib. That is what I look at.
I agree with you. So in fact, in second line, many times we don't only use docetaxel. Many times we end up using two drug agent when you have a good PFS in that situation. So I do agree with you. It is not that you can't use it. That's the way the docetaxel was developed, because the median PFS is 5-6 months. So that's why docetaxel alone was developed. But that was for median majority of the patient. But in our clinic, we do get the situation what you said, and now more often because of these drugs.
Give us other options. We have learned from you utilizing reach and carbo. I have observed it one of the most effective options in 4 and 5 lines. So that is one of the most effective.
I agree with you. That's easy to use. So if you get a gap, then revisiting is not a bad idea.
It's different from prostate cancer, where docetaxel rechallenge is never in clinics we have seen. But here, carbo rechallenge has got them significant.
Agree.
So we'll go.
That means the third generation EGFR-positive not available in the slide now. So could be wise option to continue osimertinib and amivantinib. That could be one option.
So people have done that. People have done that. It was not available. Now also in India, there are people who does that. So I guess that unless these drugs are very different, it's a different issue. Otherwise, looks like it will give us a similar kind of similar toxicity also.
If you look at the curve for lazertinib, osimertinib, and amivantinib, lazertinib, the curve for lazertinib, osimertinib is overlapping. Yeah. The only thing is that lazertinib in that study somehow had a lot amount of venous thromboembolism events, which is the tune of around 39%, which we had seen.
So it's doubling of the ILD as well.
So we'll take the next question, and Akhil, you can take it. The mic is with you. Any impact of performance status and age on response of amivantinib?
Yes, 70 madam showed that year 0 had the best responses. This is a drug where since it's a monoclonal antibody, if we are able to sustain the full doses for a longer time, it seems that it will work better, and that is the reason. If PS0 is there from the baseline itself, it will act better.
So there's more likelihood that if you use it early, the patient might benefit from it early. Samir, does the variance in Exon 20 make a difference with respect to amivantinib? Or all variants you are only giving the amivantinib?
Basically, it acts on the extracellular domain of the receptor. So whatever the variant and data shows like to was maybe I think we have mutations are better out.
But it is not statistically significant, so we can conclude that all of them have a Ankur, the bispecific nature of amivantamab, how it is useful? So we have covered question number 5. Ankur, you can start with next one. Do you think amivantamab has a role in brain mets?
Personally, I have not used in any patient, but we have now seen that antibodies do have response even in brain mets as well.
Akhil?
Yes, sir. As we have some experience in utilizing amivantamab in brain mets as well, it was thought that amivantamab is a big molecule, it might not penetrate brain, but there is clear responses to it from the trials as well. 45% patients in the trials have brain mets.
Correct. Even it's a big molecule. In fact, this ESMO issue, there was a presentation on which they were specifically talking about outcomes of amivantamab and brain mets, and as you correctly pointed out, this has an impact on that also. With that, any final comments on amivantamab? Any take-home message? One line from each of you.
Utilize this drug as early as possible, because keeping it for late will definitely reduce the benefit from the drug. This is a toxic drug. Manage it carefully and educate the patient clearly.
So we should not be scared of the side effects because they respond to dose interruption and dose reduction. So we should use it, follow the guidelines, and it's the only way, because it is going to cause side effects, like Akhil also said.
Samir?
Sir, really exciting that we have, especially patient post-traumatic intervention, where we are struggling to use any standard therapy. So I think that is it is going to make a big impact, because it's not going to be activating patient, but also see the one of the routine situation in everything.
Exon 20 insertion mutations, we have got close to 70 patients in the last 6 months, so it's not a small number. Exon 20 insertion is very common now.
Let's give it that Varanasi has a big number and Samir has a small number. Ankur, your answer.
What kind of patients is not better in the second line setting? Broader molecular analysis, we must define more which patients to benefit more giving this drug in different situations.
That Mariposa data is supposed to come in ASCO about what secondary mutations. The take-home message from my side is that this drug has allergic reactions. Just don't forget that this can also cause keratitis, because commonly I've seen that people forget to do ophthalmic examination before you start this drug, and look out for interstitial pneumonitis with this drug. It can rapidly sometimes cause interstitial pneumonitis. With that, I thank the panelists and the audience for the nice discussion. Thank you.